So in terms of today's talk, I thought I'd look at these 4 issues. Can spinal pain sometimes be less about spinal tissues? If so, what else could it involve? If there are these other things, can we actually identify them to any extent? And then if we can identify them, can we actually do anything about them? I will preface my talk by saying I'm particularly talking about persistent pain. So the kind of pain that stays, lasts, and becomes a bit more disabling. And that applies to the vast majority of back pain, but obviously we're not talking here about cauda equina syndrome and back pain related to cancer or other red flags. Now the obvious starting point is the evidence that shows that the way we've managed persistent spinal pain like back and neck pain, that it hasn't been ideal. So if we look at these graphs, this is data from America, but it's pretty consistent across most countries. We'll see that the number of MRI scans, morphine prescriptions, epidurals, lumbar fusions, which cost big bucks, the number of these over the years has been increasing steadily. But that could be a good thing if outcomes were improving. This slide, in contrast, is more worrying. So what we have here is we have, on the left, not the number of people with musculoskeletal conditions, but the likelihood that if you have it, you're disabled. So if you had persistent, in amongst these, the big ones are back and neck pain. If you had one of these conditions back in the 90s, you were much less likely to be disabled and off work and requiring social insurance payments. So that's getting much, much worse. Now, sometimes people think, well, that's because nowadays we're less active and more overweight. But those factors are probably a confounder for cardiovascular disease and circulatory conditions as well. So what's going on? Somebody with blood pressure and angina 20 years ago, their risk of being disabled now is a bit less. Somebody with back pain and neck pain 20 years ago, their likelihood of being disabled is increased. And I guess, as a physiotherapist, I shouldn't say this next line, but if you were in charge of the health budget and you saw that graph, would you keep giving money to people like me? Because it doesn't look like we're delivering a particularly good bang for our buck. And we really need to think about why is there such a contrast with circulatory conditions when there are some common factors like physical activity and obesity. In other words, something needs to change about the way we've been managing back pain. And I'm not here to criticize individual treatment approaches, but what we can say is we've tried lots of treatments. Various forms of manual therapy, different forms of exercise, different forms of injections, pills, needles, surgery. And they all offer something. But in all the trials, once you control for placebo effects and dosage and so on, none of these interventions appear superior. They have a little bit of an effect on pain, a little bit of an effect on disability. So we're not rubbishing them, but because some people do benefit, but the effects are not that consistent or predictable. Now, to be a little bit provocative, we've got to think, why are the outcomes so poor? And I think this depends on your bias. Do you see yourself as a clinician or an academic? But here are some of the reasons people suggest. One thing academics might say is, look, the treatments these clinicians have been using are very poor. And those of us who still work in clinical practice often don't like hearing this. We might prefer to hear that we'll say, well, the treatment is fine, so the manipulation or the injection of the pill, that's fine, but the way they did it in that study wasn't optimal. So we can keep going and doing what we have always liked doing. A lot of the time, things like back pain get a bad press, and we say, well, my treatment is fine, but those people with back pain, they're beyond help. Nothing can be done for them. You might say the research is bad, and again, RCTs are a little bit artificial and different to normal clinical practice, so you might use that as an excuse. We're often very tempted to say, well, it's the patients, these bad, naughty patients that don't want to get better. But that's a little bit too easy. I think some of the things we need to think about in terms of why are the outcomes so poor, we have to come back to what do we think we're treating? Because our beliefs as clinicians will drive our behaviors. Most interventions that I've described, they focus on treating one dimension of pain. So treat the inflammation, treat the pain sensitivity, treat the posture, treat the spinal mobility. And many of these interventions are still based on an outdated tissue injury model, this idea that pain and injury are very closely connected. So, to challenge the idea that RCTs can't prove clinical effectiveness, I want to contrast it with one simple example. And the one I'm going to take is something like hamstring injury, which for many years was considered very difficult to treat and very recurrent and difficult to overcome. But we've now had a good few trials, and many of the people here will know more about those trials than I will, showing that if you do something like strength training for hamstring injury, you get large effects once it's done, what we'll say, properly, graded progressively and done hard enough and maintained over time. In other words, yes, people with hamstring injury, it can be a tricky injury to treat, but RCTs do show an effect. these RCTs also show that if you compare, say, strength training to walking or stretching, there is a difference in the effectiveness. In other words, it's not just accounted for by exposure and placebo effects. What's confusing for some people then is if we look at a trial of, say, persistent back pain. If you have one arm getting strength training and one arm getting a walking program, there's no difference in effectiveness. So why is there this contrast? Hamstring injury, strength training is better than walking. It's better than stretching. With back pain or neck pain, strength training doesn't have any different superior effect to any other form of exercise or actual manual therapy or injections. Why is that? And I think it comes back to the mechanisms. Hamstring injury and back pain, they might both be considered musculoskeletal conditions, but they have different underpinning mechanisms. So here we're back to this idea of whether pain and injury are similar. Hamstring injury is an appropriate term, I think, based on the idea that the person is pain-free, they do a specific thing, they get injured, and when you take a picture of somebody's right hamstring 2 days after being injured, it looks different to their left hamstring generally, and it will also look different to the hamstring of somebody who hasn't been injured. So the tissue is injured, and it will generally go through a typical tissue healing response. Low back injury is a commonly used term. How often do we think this is an appropriate term, where it behaves in the way that a hamstring does? And I want to contrast it with other parts of the body where we don't necessarily throw around the term injury. So for example, if we contrast it with headaches, if I walked into a physio or a GP or a chiropractor holding my back and grimacing and limping and looking uncomfortable, people might assume I've injured my back and start treating it as an injury just by the very fact that I'm sore. But if I went in complaining of terrible headache, they wouldn't assume it's an injury. We would try and figure out what else could be causing a pain in my head. And we're quite comfortable with the idea that headache is an acceptable term, but backache seems not very scientific. We should probably think about why that is. And then there's the issue that if I say somebody's back isn't injured, they might think I'm saying it's psychosomatic or all in their head, or they're faking it or looking for attention. And that's definitely not the case, but we have to come up with a way of explaining that to the person so they feel their pain is not being rejected or stigmatized, and that they feel we're empathizing with their distress. So, can it be less about spinal tissues? The data is pretty clear that it can be. So there's lots of things I'll try and differentiate when I'm talking about my opinion and when I'm talking about data. But the data on this is very, very clear-cut. Lots of people, if we scan all the people in this room, don't be too distressed about it, but most of you are going to have disc degeneration, most of you are going to have some disc height loss, and that doesn't necessarily mean that there's anything wrong with you. A lot of the stuff we see on scans is a bit like wrinkles and baldness and so on. It's related to genetics and aging. It's not necessarily a pathology. We are not just our scans. However, it's not that clear-cut. Sometimes the stuff we see on scans is relevant. So the same group have done both of these reviews. Their first one showed on their own scans don't mean a lot. But on average, if you take a group of people who have back pain, they have a little bit more stuff, to use very technical language, on their scans than people without back pain. And this is a bit frustrating because we want a nice simple answer. Either scans are completely irrelevant and are the devil's work, or they are wonderful and the source of all wisdom. And of course it's not that. They're very useful for ruling out red flags. And all we can say when we look at the scan findings is that there's a little bit more stuff on average in people with back pain. But trying to differentiate when that is relevant and irrelevant is a big challenge. What's more clear-cut is that in early MRIs, so sending a person for an MRI in the first couple of weeks to a month is generally a very bad idea, unless there's very clear indications. And you all know what I mean by the clear indications. Serious red flags, bladder bowel disturbance, weight loss, those kind of things. And there's been a whole heap of studies, this is one of them, showing that if you have no clinical indication for an MRI and you get sent for an MRI, your outcomes are worse. You end up more disabled and more likely to go for surgery. And we can come back to why that might be the case. And remember, this is consistent with what we see in other issues. So one of my PhD students, Sean, he's just published a systematic review looking at whether looking at tendons predicts future injury. And again, on average, it does. So on this meta-analysis, what we're looking at here is, on average, you are more likely if you have abnormalities, I use that word cautiously, Paul and Andrea would say we should probably talk about morphology, but changes in tendon morphology increase your risk of getting future symptoms. So whether we're talking about the spine or whether we're talking about lower limb tendons, having a bit more stuff in your tissues does increase your risk. It's just that it doesn't explain it all. So where does this leave us? Because we're back to this issue now, well, is it in the tissues or is it not? And 90% of back pain is given this term of non-specific back pain. What does that mean? It means that for 90% of people, all or most of their pain can't be explained by a tissue diagnosis. So for most people, it's not about their disc or their facet on its own or as the predominant cause. I suppose my challenge here is that what do patients get told? Because I would say it's no way that it's only 10% of people that get a tissue diagnosis. Because I know myself, I've spent far too long telling people, oh, it's your disc or your facet or your whatever tissue I want to blame. But the findings don't back that up. The challenge, though, is what do I tell them instead? Because sometimes patients and clinicians are very uncomfortable with diagnostic uncertainty. And there are some pros and cons about diagnostic labels. For example, if I was to ask the group of people here, if you take a word like fibromyalgia, if a patient is diagnosed with fibromyalgia or chronic widespread pain, do you think there will be some of them who will be relieved and reassured that thankfully it's great somebody has figured out what I have? And equally there will be others who will be traumatized and horrified at being given a diagnosis, because what will they do next when they hear fibromyalgia? They'll go into Dr. Google and check out how it ends up for some people. So a question, and I think it's something for us to think about, is if we're agreeing that tissues can be part of the problem in back pain, but they're no way the most common factor for at least a considerable portion of people, what do we tell people is wrong with their back? I don't have an answer, just to be clear. So in terms of are the issues in the tissues, it's clearly not all about spinal tissues. That's almost not up for negotiation at this stage. But it's foolish to say the tissues are irrelevant. The tissues are one source of input into your system, and then that input is open to modification and interpretation. And that's what I want to talk about next. Now, in society, we've been brought up with the idea that there is this line here, which is your pain threshold, and it's a flat line, and it's way up here, and when you experience pain, it's because something like this happens. You get a kick in the shin, or you get a sprain in your ankle, and the threshold is breached, and for a period of time you get some pain, and then normal healing occurs and the pain goes away. And again, this model works quite well if you think about hamstring injury and sprained ankles, acute sprained ankles. However, if you think about people with persistent spinal pain, that graph doesn't reflect what's happening at all. In fact, what seems to be happening is if their pain threshold was there, they're doing things like this that seem to be painful. So they're saying, well, when I roll over in bed, which we all know is not a high load activity, or when I'm sitting in the car, which again is not such a high load activity, I'm getting significant pain. So what's going on? How can they be experiencing pain in that situation? A couple of possibilities. Number one, what if they have some peripheral nociceptive input that increases the noise into their system? Another possibility, if we look at people with pain, do you think they move the same way as people without pain? Absolutely not. So if one of the things, the most common physical finding that you can consistently reproduce in people with persistent back pain is an absence of relaxation. So the flexion relaxation phenomenon is when you are able to bend forward and relax your back muscles. And an absence of relaxation or increased compression is the most common clinical finding. So as a little experiment, I want you to all make a little circle with your wrist. So keep your wrist nice and relaxed. Make a nice little circle, no big deal. Compare how much clicking and creaking and compression you feel that way versus doing it with a clenched fist. And you'll notice just a little bit of difference. Now again, don't worry about it too much. It makes perfect sense that when you increase the compressive load through a joint and then try and move it, you're going to get more input and signal. When we look at people with back pain who are doing things that look a little bit like this, the bottom line, but they move in a very guarded, protected way, it increases the signal. But again, it still shouldn't cause an awful lot of pain. So even if I get you, can I get you all to stand up for a second? Now we'll come back to advice around whether you should be tensing those muscles and all that later. But you could probably all feel an increased compressive load on your spine, agreed? However, for most of you it still didn't hurt. Would you agree? It felt a bit weird, it felt unnatural, you're glad I asked you to stop, but it still didn't hurt because even when you tense your body, it shouldn't hurt because your pain thresholds should still be high enough. So as well as increasing the physical input from the periphery, we're probably also talking about a reduction in pain threshold in these people. And we've seen this objectively. You know, I won't even present all the data that's there to show that people with persistent pain have a much lower pain threshold. Now this is a bit tricky and a bit confrontational because I'm sure you'll have seen this yourselves. I've seen patients where they will say things like, very few things patients say frighten me, But when I get patients who come in and say, I have a particularly high pain threshold, I get a little cold shiver down my back. Because generally what do I find when a person says that? Almost the complete opposite. Now, we've got two options. Either they're lying or they're reporting something different. And I think they're reporting something different. Because people with persistent pain, particularly the most long-standing and disabling, their pain threshold is on the floor. Very light touch hurts them. Very subtle changes in temperature hurt them. Yet they say, I've got a great pain threshold. I think what they're saying is, I've got a great pain tolerance. Because they're probably in the situation like this line here, where they're experiencing pain most of the time, but they're not complaining about it. So they would say they've got a great pain tolerance, and they're only complaining when it becomes very, very extreme. Now, my question to you is, what factors might reduce the gap? What we're talking about in a perfectly healthy person is high pain threshold, it's hard to cause pain, and gentle movements like rolling and bending don't hurt. What are the factors that reduce that pain threshold, the level at which you might experience pain in any person, never mind people with persistent pain? Sleep? Stress? Being physically active or inactive, yeah, will affect it, yeah. Anything else? You're right, I'd agree with all those. How about depression? How about fear and anxiety? How about hormonal fluctuations? Okay, so there's a whole range of factors, and these apply to normal people without ever having pain. The other thing I want us to think about is, I've represented that pain threshold as a flat line, but that's not normal. That's the way we picture it, but of course it's not normal. In fact, a normal person's pain threshold is probably a bit more like this, because for all of us, we'll have a couple of nights where the kids don't sleep, we'll have a day when work is a bit more stressful, and if you're just an average woman, every month your menstrual cycle will cause subtle but normal changes in your pain sensitivity. So what I want us to think about is, how does this interact with recurrent back pain, and explain some of the changes we see in patients, where trivial things, honestly, people will say things like, oh, when I'm getting out of the chair, my back hurts. When I'm rolling in bed hurts. When I go to lift one of the kids, it hurts. Now, there is a little bit of load involved in these things, and they can be done in abnormal ways, but these are not physically damaging loads. The body is much more resilient than that. And that's where we should probably try and spend some time trying to differentiate between people who have a sore back but are generally healthy, and people who have widespread pain and very atypical pain. And rather than seeing these as being one extreme and the other, so I've got a sore back and I'm sick, very sick and very sore, there's probably a spectrum of presentations where their presentation can get increasingly complex, because their physiological health, their sleep, their wellness, their fears, their worries, their anxieties, their activity levels can increasingly become problematic. So we've already touched on some of this, but what else could it involve? And essentially, I'm trying to be clear, we're not excluding the pathoanatomical factors. They clearly have a role. It's just that it's nowhere near as big a role as people on the street think. In fact, what do you think would happen if we went out onto the streets or went into Villaggio and we said, there's a talk on this morning about spinal pain? What do you think people would think we were all going to be talking about? Disc bulges and MRI scans, and then the dangerous things like heavy school bags and sitting posture. And again, I'm not saying these are irrelevant, but that's where the public narrative is. And if we really want to make a change in public health conditions, like lung cancer, you had to change people's beliefs about smoking. If you want to really change, things like obesity and cardiovascular disease, you really have to get people to understand the role of diet and physical activity. And we won't change really in a meaningful scale back pain outcomes without people understanding or viewing differently what back pain and neck pain involve. So pathoanatomical factors are there, but physical factors are there, and we'll come back to those. But what's less focused on is the lifestyle factors: sleep and physical activity, psychosocial factors, depression, sleep, stress, fears, worries, anxieties, how these all interact and sensitize our central nervous system. And of course, what I'm not really talking about today, but there is of course genetic links in this. In terms of the physical factors, I was talking to Ken just earlier about how your message is going to be slightly different depending on whether you're talking to your own profession or a bigger range of professions. So I'm going to keep this pretty broad. I want us to think about, with physical factors, can they increase the peripheral nociceptive input? Can they take that little bit of signal from a sensitive disc or a slightly degenerative facet joint and increase it by persistently provoking it? So one example I gave you before was the wrist. And what we see with back pain patients, particularly those with most disabling pain, is they cannot switch off their paraspinal muscles, which increases the compressive load. So there is that potential. A more challenging thought is, have we added to the problem? I say this about myself because I think I have definitely made the problem for a lot of people worse by fear-mongering. I was trying to do the right thing, but I made people feel very bad about things like posture and manual handling. So I'm only half joking when I talk about this, but I'll say we have a couple of kids at home. They're 3 and they're 1. And the 3-year-old now, he's starting to become a bit more active. And I see him now and he's going around picking up toys around the house. So am I increasing his risk of back pain? And of course, it's hard to justify that. And some people will say, well, what about if you're lifting 50 kilos? And of course, these are higher loads and it's very important to lift them safely and sensibly. But most people I see are not getting pain lifting very heavy loads. They're getting pain rolling and bending and walking and jogging. Again, not putting huge compressive loads. So how much time have we spent trying to tell people that if they sit slouched, they get back pain? Now, don't move. But what way are you sitting? And what do people generally do when I tell people I did my PhD on sitting posture and back pain? They almost feel like they're going to get put on the naughty step again for not sitting properly. And if I asked all of you to sit properly, you wouldn't stay like that. And why? Because it's bloody uncomfortable. So we have certain beliefs about the spine, and they haven't all necessarily helped. Is the spine that different to the knee and the wrist? So I spoke about the wrist, but even if we talk about the knee, so normal level of resting muscle tone. So if you look at an OK magazine or a men's fitness magazine, you would start to think that the resting level of muscle tone was something like a wall. You know, it's like, and that's not normal. And unfortunately, a lot of patients are told by people like me that, you know, they need more tone a lot of the time. And in fact, what we see over time is the opposite, an inability to shock absorb and to move with confidence and freedom. So if you think of the best athletes you see, they're very strong, very fit, but agile. They have not lost that ability to shock absorb and move with confidence. And if we look at something like the people returning from ACL problems in the knee, they need that ability to shock absorb and generate power. And you cannot generate power and torque through your spine by being rigid throughout. And while I talk about, you know, pain thresholds up here and the input being below, we got to remember the body and mind are very closely connected. So if somebody's got very tense back muscles, it's not disconnected with the fact that they think their back is damaged and bending is dangerous. And there's very clear correlations between high levels of fear and high levels of muscle tone. So if I want to make somebody's back muscles less tense, it's no good rubbing it and stretching it and then telling them, if you ever bend again, your discs might explode. That's not going to calm down that level of muscle tone. So if I was going to be critical of myself about the way I've prescribed exercise in the past, I would say I gave with one hand because I gave people exercises. And again, the exercises generally are all very safe. I don't have a problem with any of the exercises. But I tended then to kind of sell sickness by kind of saying, well, you do this exercise and it helps because your discs are damaged, or because your pelvis is weak, or because your muscles aren't strong enough, or there's something inherently wrong with your body. Instead of just giving them the exercise and saying, this will help and it's safe and do carry on with it. Can we identify these other factors? I'm going to talk about a few things, but I'll be provocative with the first one. In terms of these other factors, I'm not only going to talk about yellow flags. I think the most important markers are actually the things we already screen for. Some people ask me, like, what kind of profession and skills do you need to manage persistent back pain? I think GPs are in a great position to understand the patients who get persistent back pain because they understand their patients well and they see them for their low energy and their sleep deprivation and their myriad of other, subjective health complaints. And we often screen for things like sleep and activity and obesity and energy levels. And these are really important, but when we see the picture of the MRI scan, that can sometimes just get pushed right up to the top of the pecking order. And the role of these very important systemic factors is underestimated. And then I'll talk about yellow flags. And physios kind of give yellow flags a bad name. And so a lot of time I get asked, how do you identify patients with yellow flags? And what I say to the physios, to be a bit provocative, is, well, first of all, you get a mirror. Because if you think back pain is very dangerous and it's very dangerous to bend, your patients probably will. And you shouldn't be surprised then if they're very nervous about their own back pain. But beyond being a little bit provocative, we do need to look at our own beliefs. If we think the back is very vulnerable, our patients will. If we think exercise is dangerous, our patients will. We can, of course, use questionnaires, and there's a whole range of them, and they are reasonably valid and reliable. They're not perfect, but they can, if you're in doubt, give you a reasonable indication of how much is this about the person's back and the tissues in their back, and how much it is about, yes, their back, but also their wellness and their systemic health. Malcolm Gladwell wrote the book Blink. Some of you will have read it. And it's about the idea of being able to make quick judgments, which can, of course, sometimes be very good and sometimes be very bad. But I talk to students about this, that our ability to identify complexity in yellow flags, sometimes it's actually using very simple things. For example, when I was living in Ireland, sometimes patients would ring and look for an appointment, and my wife would answer the phone, and then she would be annoyed with me for not answering the phone, but that's a different argument. But within her priority when she'd answer the phone was basically, hello, he's not here, what's your name, goodbye. That's all really she wanted to do. But even in that 30 seconds, she could identify pretty well whether it was going to be a simple, quick, see them once or twice, they'll be fine, or another case where she'd say, ha, good luck with that. How did she do that? She wasn't using an Arbor questionnaire, she wasn't using any advanced MSK triage system. What do you think she was doing? She was listening to their tone of voice and their expectations and what they said about it in a short period of time. On one evening, for example, one guy rang and she said, my husband isn't here, can I take a message? And he said, yeah, look, I hurt my back a few weeks ago. It's better, but my wife is worried that, I shouldn't be doing as much work and I'm gone back working, and she said I should get it checked out. So tell him there's no rush, give me a ring when he has a chance. Okay? Not high risk. The second person who rang was a lady, and my wife said, sorry, my husband isn't here, can I take a message? And the lady's first response was, there was a pause, and then she said, nobody's there when I need them. And without hearing any more about this poor lady, she didn't fill in a start back questionnaire. The poor lady was very distressed. And when she turned up, true to form, she had been through a long, hard process. And she needed a whole range of supports. My point here is, and I'm being a little bit flippant, but just listening to our patients and not rushing straight for the tissue diagnosis can tell us a lot about how distressed they are and how complex their life story is. Another thing as well is, because I bring up those kind of half-joking things about, stress and mood, are all these things abnormal? Is it abnormal to have had a period where you didn't sleep for a couple of nights, or to be very stressed, or to be a bit fed up? Is anyone here going to really tell me they've never experienced any one of those ever? Because if it is you, good luck to you, but you're the weirdo. And this interaction of kind of biological and psychological and social factors isn't just around back pain. So I often try to kind of reassure patients that, it's not just you, it's me. This is common. I'll exaggerate how many different ailments and health conditions I'll have, just to kind of reassure you that I'm not judging you or thinking you're fundamentally weak. So one of the examples I gave is that, a couple of years ago I got a cold sore. And, it's not the most devastating illness in the world, but, it was an issue for a few weeks. And I think it was this guy's fault. Now, why am I blaming him? Because he was born about a month before that, and I was, don't worry, compared to my wife, I was sleeping pretty well, but I was a bit sleep deprived, probably a bit over anxious, probably not exercising, probably not eating as well. So in other words, I would say I was a little bit run down in layman's terms. The thing is, if you look at it from a biological point of view, what causes cold sores? There's a virus. So it's not just stress and sleep and exercise. So if we think back to that example of the threshold and the input, first of all, we should figure out, where's that cold sore virus gone now? Because thankfully I don't have it now. So it's gone completely, isn't it? No. Oh, where? Should I be worried about it? What if it exploded at any moment? My point here is, if you think about that pain threshold sensitivity thing, I still have that virus. So it's probably, if you think about that input, it's probably still there in my system. But my threshold, my immune system is, thankfully for the moment, a little bit better, even after the driving in Doha, which honestly stressed the hell out of me. But at that period of time, my pain threshold, my immune system was compromised and it improved. But again, we have that interaction. The thing is, because my cold sore was visible, nobody suggested, Kieran's got the psychosomatic cold sore. But what if I'd got some back pain or neck pain around that time? And my MRI scan was clear. People might have said there was nothing really wrong with him, when what they mean is, well, his scan is clear, but he still has pain. And I want you to think about the number of women we see with post back pain and pelvic pain after having a baby. where of course there's been a physical load during pregnancy and a physical trauma at childbirth, but how rarely we look at the role of sleep deprivation and exhaustion and stress and anxiety and isolation and mental health problems in those populations. In other words, for things like cold sores, you need the biological trigger, the virus, and then the immune system vulnerability. I wanted to think, how does this apply to people with a rotator cuff tear in the shoulder? Is it enough to have just rotator cuff tear? No, but it could be one part of the problem, and then if your cuff is weak and your immune system is compromised, you can get pain. So Sive came along a couple of years later, a prize to anybody who can spell Sive, by the way. I didn't get the cold sores. Was I sweating and anxious in advance of her being born? No, because I understood what was going on. But we do sometimes see that with athletes and patients where they say, well, I'm about to go back to work and the last time I went back to work it happened, or I'm about to go back into pre-season training and the last time I went in it happened. Unless the athlete understands why I broke down the last time, they will be understandably anxious about the return to sport or the return to work. So getting the athlete's head around the problem is key to reducing their fears and anxieties. Can we do anything about these? I'm a physio. I spend lots of time learning anatomy and biomechanics and then stuff around posture and manual therapy and so on. I'm not an expert on diet or on mental health or on, workplace relations. So I'm not going to try and be an expert in all those things, but we probably have to be more flexible in our practice and acknowledge the scope of our practice is still a bit limited. So for example, if you look at something like obesity, I'm a physiotherapist, I won't be the solution to obesity, but I will have people who will present where obesity is one part of their problem. Should I never mention diet and obesity? Just kind of don't mention it at all? Just let that be somebody else's problem? Or should I support the dietitian and the nutritionist and try and help the patient understand that I'm not going to be the person giving you the dietary advice, but it's important to acknowledge diet and obesity are part of your health condition. And in the same way, I'm not going to be treating somebody with post-traumatic stress disorder or suicidal ideation as their primary caregiver. But I can reassure them that that's worth looking after and that's at least as important in your pain as that minimal disc bulge that you think is important, without dismissing it in any way. And remembering that most of the stuff we talk about in terms of fears and anxieties aren't terribly, to use that term, psychopathology. They're not kind of very serious psychological conditions or psychiatric conditions. A lot of it is, I'm worried my back means I won't be able to play sport. I'm worried my back means I won't be able to play with my kids. Somebody told me my scan looked bad and I'm a bit anxious about that. The reason, so I gave a talk last year at a conference, and my point was that in back pain, if all I have is a hammer, all I'll see is nails. And if all I think about is posture, that's all I'll see. So we have to think a little bit more broadly. Can it work? Essentially, I won't go into the trials too much, but there's been 2 trials showing that adopting a slightly broader approach can be effective. So the Norwegian trial showed pretty good effects. So this was a trial comparing this approach called cognitive functional therapy to a traditional manual therapy and exercise program. And essentially, what's important to point out is, this is dying. The manual therapy and exercise did work. So if we look at the manual therapy, it did improve over time, but the other arm, which involved basically looking at more than just manual therapy and exercise, improved more, and the 3-year follow-up is consistent with that. And we've just finished a trial in Ireland. This is Mary O'Keefe, who's just completed her PhD on the topic. The treatment is finished. We're about 2/3 of the way through the 12-month follow-ups, so we don't have the completed data yet. But based on what we've seen so far, the reductions in the intervention group are over twice as good as the control arm, which is, again, what we would hope to see. So based on those trials, I'm saying it's too early to say definitively, this is going to change how we manage back pain. All I'm saying is it's encouraging, and if we look at the mechanisms underlying back pain, it makes sense. And it's also consistent with RCTs by other groups in, for example, Britain and in Central Europe. I think we can do a lot better than we've done in those trials, though, because it's important to say we've included in these trials, particularly the Irish one, the difficult cases. So we didn't exclude people with medical legal compensation issues, with surgery, people who have pain for a long time, people who are off work. And that's something that's important to look at in trials. I've seen people looking for funding for back pain trials, and they'll say back pain costs billions. And then you look at the people they're including, and they're only including people who are like us, who are at work and have a small bit of discomfort. So it's important that we include the difficult cases to understand that. Both these trials only included one discipline. That's not optimal. We definitely need more disciplines to be involved. Although again, it's important those disciplines are speaking the same language. They didn't involve booster sessions, so we treated them for a period of time, something like 6 to 12 weeks, and then abandoned them because that's what you do in a trial. You have a clean follow-up period. But in turn, in managing mental health and obesity and other chronic diseases, we wouldn't abandon people. We would be available for support if they needed it. So I think we can improve that further. And again, this was without technology, which again might increase the effect. We were also, in terms of the difference between efficacy and effectiveness, we were starting to look at effectiveness in more like in a real world setting. So again, if you really wanted to step back and do a true efficacy trial with more control, you could probably see better effects. All I'm saying there is there's room for improvement. We can even do better if we have multiple disciplines speaking a common language. So it's on that topic of consistency I'll finish off. Because management of spinal pain is far from consistent. I really don't want us to sweat the small stuff. Sometimes the physios get very hot and bothered about whether you're doing, to use physio language, a grade 3 or a grade 4 mobilization. Honestly, if that's all that's wrong with back pain management, we'll be fine. What's more important is that we have a common philosophy and a common language. So some considerations. 5 things to go through. Low back pain is a predicament of life. Norton Hadler's book, Worried Sick, talks about a range of healthcare conditions. And I think we need to view back pain, persistent back pain, recurrent back pain, more like tiredness, sadness, and constipation. Not fun by any means, but common. And these really aren't diseases if they're present for a few days intermittently. So I don't want to get back pain. But if I get back pain next year for 2 days and 12 years' time for 3 days, I can live with that. That's almost normal, same as being tired for a few days is. How realistic is it to prevent them completely? Do you actually think it's a sensible strategy to spend a lot of money trying to prevent pain-free people ever getting back pain? Because I think that's about as foolish as trying to prevent people ever getting tired or ever getting sad. It's much better to focus on how do we get people who are sore, get them better, or to prevent secondary recurrences. Persistent disabling back pain is the focus, not preventing of niggles now and again. In terms of imaging, again, if in doubt, screen appropriately. But the doubt should only be when there's significant red flag issues. And then explain the findings appropriately. So we did an editorial in BGSM recently talking about the CLEAR principle. So you use clear language, epidemiological information to say how common this is, and applied relevance so it's always related to their clinical findings. And if it's not dangerous, if the findings are kind of benign, definitely tell the patient that this is not a bad finding. And there's been a good few studies looking at the idea that if you do MRI scans and you tell people this is not bad news, in fact for a person of your age we would expect to see this even if you didn't have pain, that it can have significant benefits in terms of people being prescribed medications and so on. Whether injury, the difference between injury and pain, and I suppose getting a common philosophy around this. Again, if it's truly a tissue injury, like a hamstring injury, by all means treat it as a tissue injury. Load tolerance, tissue integrity and so on. But if it's not a tissue injury, which is very, very, very common in persistent spinal pain, don't treat it as an injury. And the reason I bring up this last point is around how people define they have an injury. I've had situations where people say, have you injured your back or neck? And they'll say, oh yeah, I did. And I said, could you tell me about it? Oh, when I was 12, I fell in school. And you kind of say, right. And have you had pain since then? Oh no, it's been fine since then. But they think that this innocuous injury 30 years ago is coming back to haunt them right now. When I'm talking about an injury, it's like a hamstring injury. You can say, I hurt it today and I got pain today. And even if it did start as an injury, so I was involved in a whiplash or an occupational injury at work, does it still behave like an injury? So it started as an injury. Is it still behaving that it's made worse by certain things, better by some things, and it's following a tissue injury model? Because again, a lot of the time it starts with an injury, but then other factors become the dominant issue. Some things, again, to be a little provocative. What activities do we think are truly dangerous? For the population as a whole, what things do we think our bodies and our spines truly cannot do? Because I'll hear endless amounts of patients being told, well, you need to get fit, but don't run, don't swim, don't go to the gym, don't lift weights, don't, and don't. But get fit and get strong. And we end up excluding lots of things because we're afraid it's damaging. Now again, I'm not saying these things can't be painful and provocative, and we should try and make them as comfortable as possible. But we probably need to be careful about excluding activity from people's lives. And even for high-load athletes, it looks like being used to the activity or being not used to the activity is the risk factor rather than the activity itself. In other words, if I'm going to get pain lifting, it's more likely to be that I'm not used to lifting than the lifting is dangerous. So for example, if you want to look at Tim Gabbett's work on the acute chronic workload, to to be safe when sprinting and training, you should practice that quite a lot and do it consistently. If you want to be safe lifting, our current model is whatever else, avoid lifting. Get all the slings and hoists imaginable and avoid lifting. And we don't do that with other parts of the body. We will try and make that, condition that body, and obviously do it safely, but condition it and get it better prepared for that. And then finally, how do we learn to move? If somebody cannot bend and cannot twist, how do they get there? Is it by practicing the movement or training some muscles? Because again, my kids didn't learn to roll and bend and twist by activating their glutes. You know, the way you must make your glutes fire, you know? They did it by moving and rolling and bending. So there's probably more of a role for that functional approach than just training muscles. In other words, when I look at the way I've managed back pain and neck pain and made a mess of, unfortunately, over the years, the biggest thing I had to do was wipe my memory of some of the bad beliefs that I had. I picked them up and I imagined more of them. So you know the scene in Men in Black where they get the neuralizer and he presses the button and then he wipes your memory for a certain amount of time, 1 hour or 10 days. As a society, we need a little bit of this when it comes to our beliefs about the back being vulnerable and very easily injured. Discussing pain. Again, something that I've discussed with a few of the staff here. This can be tricky if we don't handle it properly, but when I see patients, maybe not the first day, but definitely by the second day, we'll try and address all the issues involved. We don't avoid any elephants in the room. If mental health is a problem, it should at least be brought up. Again, we're not saying there's nothing wrong with you, you're just depressed, get over it. We're saying pain involves many factors. Some of them are physical, some of them are psychological. They are all valid, they are all real. In your case, you should look at all the possible factors. Simple, clear language, and if there is any confrontation, make sure it's with as much compassion and empathy as we can handle. Because in my experience, and again the data would back this up, people are actually happy to discuss distress and have it acknowledged once their pain is not being dismissed or they're being stigmatized. A key challenge here is how do we communicate that to each other? So if I see a patient and I want to send it on to Olaf or to Juan Manuel, we sometimes are careful about what we write in the notes. So I might, in a side conversation, say to Olaf, the key issue here is stress and poor job satisfaction. But when you look at the notes I write, it tends to be, this is their age and their gender and this is their MRI findings. Maybe their straight leg raise. And we don't mention the stuff that we really think is important because we don't want to offend people and we don't want to go beyond our scope. And I think it's an interesting thing for us to think about how do we honestly communicate that information if we think sleep and stress and fear are involved in a non-judgmental, non-confrontational way, because that would be honest. So, can spinal pain sometimes be less about spinal tissues? Yes. What else could it involve? Anything that provokes the tissues locally, physical guarding, abnormal movements, but particularly central sensitization, things that run down the immune system. Can we identify the other factors? Absolutely. Can we do anything about these? A bit long, but yes, both physical factors and psychological factors. If we accept pain and injury are not always the same, and we don't view the spine as being vulnerable. To conclude, we need to screen very broadly. So even if I'm not going to be treating somebody's significant mental health problems, I should screen for them. All pain is real, even if it is related to sometimes sleep and fear and mood and anxiety. It just mightn't always be injury. If it's an injury, treat the injury. If it's not an injury, don't think about just the tissues. Check what the patient heard or thinks is the problem. Importantly, that mightn't be what I said or it mightn't be what their doctor said, but it's still what they think they heard, and that's a problem. And remember, our behaviours are influenced by our beliefs. So I will behave a certain way based on my beliefs. If we want patients to exercise, if we want them to engage in relaxation, they have to understand why that's important. Treat the person, including their tissues, but not only their tissues. I'd like to thank a bunch of people, lots of them in Ireland, some of them internationally, and that's our website. If anybody wants to send their patients to it, there's some patient stories up there. Thanks very much for your time.